Good afternoon. This is my assessment for the throats, lungs, and thorax assessment. Alrighty. Hi, good morning. My name is Justin. I'll be your provider for today. I'm just going to be assessing your thorax, lungs, and cardiovascular system today. If you have any questions, please let me know. Okay? If you need to stop for the exam for any reason, you let me know as well. Okay? You have any questions right now? No? Perfect. So all I'm going to do is I'm going to begin just by inspecting. Okay? This part's going to be super easy. I'm just going to look at how you're breathing. The noted breathing right now, patient's calm, cooperative. Patient doesn't have any respiratory distress, no cardiopulmonary distress overall right now. The next thing I'm going to do is just kind of see how you're breathing. Okay? I'm just going to put my hand on your shoulder, okay?
I have a little bit of wheezing.
You've been having a little bit of wheezing?
I'm asthmatic.
Oh, you're asthmatic. Okay. I'll be able to kind of hear that with the stethoscope. Are you having any trouble breathing right now?
Mm-mm.
Okay, good. Perfect. So what I did was I went ahead and just kind of assessed your respirations for the 30 seconds. All I'm going to do is multiply that by 2. So I counted 10 respirations at an even momentum, So she's like breathe in, breathe out, breathe in, breathe out. If the patient is like apneic or their breathing's a little like funky, I would recommend just kind of going through the full minute. But since hers was pretty regular, not really changing tempos, 10 times 2 would be 20. Okay? 20 respies is right on where we want to be. Okay, so right here, I'm just going to kind of inspect. No asymmetrical figure, no noted like asymmetrical appearance while the patient breathes. I'm actually going to put my hands like on your chest. Is that okay? So what I'm going to do is I'll meet my thumbs together, have the patient take a deep breath. During that inhalation, your thumbs should separate like roughly around the same. If you see one kind of wonking one way or anything like that, that would be asymmetry. Go ahead and take a deep breath. Perfect. So no asymmetry noted. The next thing I'm going to do is I'm just going to kind of palpate, look for any lumps, bumps, things that aren't supposed to be there, and tenderness. So let me know if you have any pain, okay? I'm just going to palpate around your chest area, and then I'll palpate your back. Kind of start supraclavicular and just kind of make your way around. I typically do it like a snake. Everyone's assessment is a little bit different. Any pain?
Mm-mm.
No? Good. We'll go ahead and check your back side really quick. The back side's a little bit easier. Very good. Okay. The next thing I'm going to do is I'm going to go ahead and since I already kind of palpated, I'm going to do something called percuss. Okay. So I'm going to lay my finger in your intercostal spaces, and then I'm going to tap it kind of hard on my joint with my middle finger. Okay. And this is just to check like resonant sounds in the lungs. So the sounds are all resonant. There was no abnormal findings. Okay. The next thing I'm going to check is fremitus. Okay. What you're basically looking for is the vibration when the patient speaks. It should be even on both sides. Okay. So what I'm going to do is I'm going to place my hands, okay, on your chest. And I'm going to have you say 99.
99. 99. 99.
Okay. I'm going to do it to your back too. This one, the back side tends to be a little bit easier to kind of measure it. Go for it.
99. 99. 99. 99. 99.
Very good. So, now that we've already kind of seen the fremitus was normal, no noted problems there. I'm going to go ahead and grab the stethoscope and we'll go ahead and start listening to some lung sounds. So I'll start with your lung sounds, okay? Make sure you switch to the diaphragm of the stethoscope. Supraclavicular. Now I'm gonna listen to kind of like the side, okay? Very good. I'll go ahead and listen to the back side. This is probably where you'll get the more clearer lung sounds, especially with the lower lobes. Lung sounds are clear. I would say fairly diminished in the lower lobes, and that was like seen or heard from me in the backside. Everyone's assessment is different. Always chart what you hear. No wheezing, no rhonchi. Stridor typically happens in the upper airway, so nothing like that. How are you feeling? Are you feeling any wheezing or anything like that? Shortness of breath? Very good. So the next thing I'm going to do is I'm going to go ahead and move into the cardiovascular portion. The first thing I'll do, just kind of measure how her heart's doing. So I'll get the blood pressure cuff out. Oh, this goes like this. There we go. There we go. Just get this on. Okay, and we'll go ahead and let that do its thing. this one will measure the blood pressure and the heart rate, but when you don't have something like that, I'll typically grab the radio. Can I borrow this? Kind of put your 2 fingers here. Okay. After measuring it for 30 seconds, I'll go ahead and multiply that by 2. Since I had 32 beats in those 30 seconds, multiply that by 2, it'll be 64. Over here, our blood pressure is reading 125/80 with a heart rate of 64. Okay, the next thing I'm going to have her do is I'll go ahead and have you sit back and then kind of put your neck back, okay? So what I'm going to look at here is for any JVD, which is the jugular vein distension. Now, most of the time when patients have this, you can definitely see it. Excuse me. So, right here, as we're looking at it, it's going to be less than 3 centimeters. Typically, you'd have the little L. But within normal patient here, there's no distension there for sure. While she's here, I can go ahead and fill the carotids. Always fill the carotids with one set first, and then fill the other side. This way I don't have to have the patient do this all over again. Very good. Stay like that, okay? Let me get my stethoscope real quick. I'll now auscultate the carotids for any bruise or adventitious sounds. Switch from the diaphragm of your stethoscope to the bell of your stethoscope. Alrighty, hon. I'm gonna go ahead and place this right here. While you're assessing the carotids, you're also going to hear the airway, obviously, because the trachea is right there. Obviously, no stridor. You will hear stridor before you even hear it on a stethoscope. It's really loud sound. Nevertheless, for the carotid, you can sit back up. For the carotids, as I was feeling them, they were a 2+, very easy to feel, very easy to see when you have the patient like this. No thrills. Thrills will be like a vibrating feeling in your hands. Nothing like that there. But everything was good there. Now, as far as cardiovascular looks, patient's not having trouble breathing. She's not blue. May I see her hand again? Go ahead and turn it like this. Right here, it's very important checking capillary refill. Most patients, with a pretty strong pulse, their capillary refill is going to be less than 2 seconds for sure. And since she doesn't have, do you have any heart problems?
No.
Since she doesn't have any heart problems, we wouldn't really know anything like that. So no cardiopulmonary distress noted in this patient. With that said, we can go ahead and grab the stethoscope again. And I'll go ahead and what we're going to do is we'll listen to the heart. I'll listen to the heart first. So, from here, I'm going to put the stethoscope in. Remember that we switched to the bell to hear the carotid, so don't forget to switch back to the diaphragm. Okay, the first point that we're going to go to. So the first point is going to be our aortic point. The aortic point is the second, between the second and the third intercostal. And it'll be like kind of to the right side of the sternum. Not mid-clavicular right side, but just before the mid. So look for that second to third intercostal space. Now, directly across is going to be the pulmonic. Beautiful pulmonic. S1 and S2 is notable here. You can hear the valves opening and closing, going down to Erb's point. Okay, perfect. Now, right under Erb's point is going to be the tricuspid. That's the one that you're going to go ahead and listen to. So from Erb's point, we'll just go ahead and go down. Now this next one, the mitral or the apex of the heart. This next one is going to be listened to with the bell of the stethoscope. On top of listening to it, you should be able to palpate it. This one is going to be mid-clavicular on the left side of the patient, kind of under the breast. So for male patients, really easy, it's going to be like right under. For female patients, use the back side of the hand to kind of lift the patient's breast, and you can go right under to kind of listen to the apex. Or you can have, if the patient's not comfortable with that, you can have the patient kind of do like a triangle, kind of lift up their breast for you, and then just kind of listen to it under. Do you prefer me to move your breast up, or do you want to go ahead and do it yourself?
You can do it.
Okay, perfect. So what I'll do is going to be kind of like mid. So from the tricuspid, you would literally just move a little bit down and to the right from where we're facing. I'm just going to go under. And with 2 fingers, you can palpate the apex pulse. Beautiful. So during that assessment, S1 and S2 noted. No murmurs, no gallops, no adventitious heart sounds. As far as the apex, I was able to palpate the apex pulse. I was able to hear it with the bell of the stethoscope. As far as the heart sounded really good. Again, no S3, S4 noted. S3 and S4 are sounds that you don't want to hear per se, because they're typically not normal. Oh my goodness, excuse me. That is gonna be it for our assessment. Do you have any questions?
No.
Thank you so much for your time.
Thank you.